She will be talking about, presenting a presentation titled, "Thank goodness somebody is keeping an eye on me. The importance of the therapy relationship and rehabilitation before and after hip and knee replacement." But the first presenter is Hoeben, and he is the Program Manager, Planning and Funding for the Canterbury West Coast District Health Board. And his presentation today is titled "Enhanced Joint Arthroplasty Management. Use of statistical methods and toolset to evaluate total hip replacement and total knee replacement pathways." So, thank you.
Thank you. Cool. So thank you for having me today, for presenting to you. What I'm going to present today is not specifically a research paper as such. It's more actually a kind of service improvement initiative that was triggered by the Ministry of Health, and that through the year 2014 I've been involved with as a program manager. So for me it's really what I try to bring home today is how in the CDHB we start adopting more use of information and data to prompt the right conversations with the services and to actually look at the opportunities within the patient pathway for improvement. So that is a little bit where I come from. We've done that with the Ministry of Health on the total hip, total knee replacement and also the fractured nerve. And the fractured nerve was definitely the area where we more statistically went into the data and where we're publishing a paper on. The total hip and total knee replacement we've done mainly just an improvement initiative, but that's a little bit what I want to present the outcomes on. So just to say, I'm just giving a little bit of background on the ERAS, the Enhanced Recovery After Surgery Program of Work. I will very briefly talk about the framework for improvement. I will talk about signals from noise, that is the toolset or the software that we use within the DHB to present statistical process control charts. Then I will run just through some outcomes for the total knee replacement pathway that we actually have achieved, and then finish with some learnings. So before talking about improvements, I just want to acknowledge that we consistently over the years see an increase in total hip replacements and total knee replacements. So, and I also want to reiterate that there is an increase in complexities of conditions and an increase in complexity of treatments also over those years. But this is a comparison from Canterbury with the other DHBs over a few years. And as you see, the Canterbury District Health Board is definitely an organisation that does a lot of knee and hip replacement. So the enhanced recovery after surgery, it was an initiative, a collaborative done by the ministry. 20 DHBs, they came together and then they provided what they call a change package. So it's really evidence-based all over the world, definitely also in Europe. A lot has been done about, hey, how do we get a patient fit for surgery? What are the best possible pathways, pre-operative, peri-operative and post-operative, and really focus on that. And also key in that thing is the engagement of the patient within all those pathways. So all those interventions, they are really evidence-based, and they actually provided a change package from possible interventions that any DHBs could take on. So we had to make it a little bit for home then. I put some forms there of such sheets of those interventions for people that are further interested. I think for the ministry, the key was really about reducing variations in care. It was really about also the best clinical outcomes, and let's be honest, it was also about a little bit being able to reduce cost and demands on the service. So that was a little bit what was all So the framework, and they also provided us support with a little bit of a framework, but within the CDHB, we are actually going, and we are still going through some changes, how we go about improvement initiatives. And I think it's based on the Institute of Health Improvement methodology. And so the principles are really establishing the aims, understanding what are the drivers, and then really identifying certain changes, establishing the measures around it, and then conducting small-scale tests. I don't know if people have heard of PBSA, the Plan, Do, Study, Act cycle. That is really a kind of an improvement, a way of improvement. We want to get away from big pilots, from big trials. We just want, when we think there is gains to be made, just start small-scale experimentation. So it's all about, and then using information and data to feed back, hey, has this made actually a difference? And to continuously improve what we're doing. So it's really being adopted, I think, through the CDHB. As the learnings will show, it doesn't come easy. Cool. So when we looked at it for the total hip replacement and total knee replacement here at Burwood, we acknowledged that in 2008, or over the years, Burwood has done a lot. And Burwood was actually already the envy of a lot of other DHBs, that we had quite a sleek pathway over here. And I think we really should acknowledge also where we come from and what we already have achieved. And when I spoke with the surgeons, Burwood was acknowledged as one of the high-performing systems, also compared to some of their private private practices or the private hospitals within Christchurch. So that was actually quite nice to acknowledge. Nevertheless, when the project team came together, there is always room for improvement, and I think definitely some variation in practices was highlighted, but also perhaps what the evidence showed, the engagement with the patients, to make the patient a little bit more engaged around their pathway, and that they could go home a little bit earlier, because that also was identified. So we came up to really focus on rewriting a little bit of pathway and create a little bit of engagement with the patients. And then hopefully we see improved outcomes, and that we also could reduce the length of stay for those patients. So out of this is for example such a private diagram that has then heaps of interventions, and it looks then at pre-operative, it looks at also primary care, it looks at different kind of bundles and what are the opportunities. So what I just mentioned before is that it was really about managing the patient expectations, and that we had an agreement that we wanted to change the pathway to 3 nights, 4 days. We had seen in the data that most patients were 4 nights, 5 days within the hospital, but the evidence actually supported that with good early mobilization that we should be able to discharge those patients where it was clinical appropriate to discharge them earlier. So we also looked a little bit at perioperative standardized protocols. We discussed bypassing a special care unit for certain patients, and we also discussed follow-up practices, so back with some outcomes around that. And then it was all about establishing the measures. The signals from noise software was really paramount for us to engage with the services and to demonstrate actually what is happening along the pathway. So it really allowed us to engage with the clinicians and have those agreements and those discussions. Just want to speed it up a little bit. So it's really all mentioned, the whole improvement is all around the pathway. We really start mapping the pathway, what are there the measurements along that pathway that we could look at and actually understand what we're doing. So that is really what it was about and what were the opportunities. So the signals from noise is a very powerful kind of software and uses statistical process control. In health, a lot of processes are very variable, and I think and a lot of variation is absolutely okay and is normal. I mean, we have seasonal variations, we have weekend to weekdays variations. It's just really understanding a lot of the variations in the process. And with the software, we actually can provide time measure data, and we actually can identify from, hey, there is something special or something strange going on here. Or we can also identify, if we make a change to the process, how a process behaves. So when you, for example, get 4 of 8 data points above a mean, then it is statistical significant that there is a change in the process made. So that is how we start looking at the data, and that is how we can start real-time providing feedback to improvement initiatives. So it becomes quite, becomes quite a kind of interactive way to work.
Could you give a little example about what one calls that bad run or that good run?
A very bad one. Just look at it. When you drive from here to Christchurch Hospital, on a normal thing it takes you 15 till 20 minutes, but then there is roadworks and it takes you 25 minutes. So that is what we call a special cause variation. In healthcare, there could be an earthquake, what was triggered, that shows then that data is behaving very different. Or when a lot of staff would have been sick, or anything like that, or a cancellation of surgery, or a big accident happening. So that could change the theatre data, how many patients were able to flow through a system. So that shows them a special cause variation. Yeah. So that is how we can start analyzing a lot of the data points and look also at significance. So we have then software that overlays the patient management system, where we can pull all the data and start really looking at it. So this is an example of software that has a lot of measures and dimensions that we can start looking at. We can break all data down in times, in facets, take it down. We can be predictive, we can put time things in. Here, for example, you see this is the point from where the earthquake happened. This was the trajectory where we were going with the attendances, what came in by ambulance. Following the earthquake, a lot of initiatives, there's a few demand, working closely with St. John, redirecting to 24 hours service. You can see what can happen to a demand on a service just by new models, new ways of working. For the fracture of that, all prevention initiatives, they have been very significantly that we now, so when we put in the data take there, from this was the trajectory, we actually can see now that we have been able to stabilize the demand on fracture of beds. Less people break their hips in the community, so that's where it becomes quite significant. So that is a little bit the software, how we engage with the service. So next I just want to talk a little bit about the outcomes around specifically the total knee replacement initiatives. So through 2014 we started to having those conversations with the project group. We had an agreement, we came to that agreement 3 nights, 4 days, and we also agreed, for that whole patient pathways to be rewritten. There was some surgical buy-in, there was a lot of physiotherapy, and I see some faces that I know that were actually also involved with it. And a lot has happened just talking about it, or reducing or making physio more available, I believe, in the weekend. All little initiatives that can help the model of care. So what I just want to do is show some results around that. So when we look here at the total knee replacement admissions, that was the trajectory, what I said in the beginning, that the demand is slowly increasing. This is the day of the week when I break that data down from when are those patients coming in. Then we see that we do most knee surgeries Monday, Tuesday, Wednesday seems less, Thursday is quite a high activity for knee replacement, Friday low activity. So going forwards, what I have done in the data shows just for the moment July as a break in the data comparing what happened in 2008 and after July. In the beginning of 2014 we agreed all those improvement initiatives, and it's amazing how that starts changing behavior when you start talking about it. It wasn't officially introduced I think the booklet came late 2014. We had around September, October, we had a little bit more clinical buy-in or agreement from hey, we're going through a 3-4 days pathway, but we actually, as the data shows, that the improvement shows before. But what this just shows is that the admissions is increased, continues to increase. It just shows that. So it doesn't. So one of the charts, what we want to monitor is the day of surgery admission. We know that it's important that patients, come at the day of surgery. So no real changes there. I mean, Burwood was doing already very well. Patients came on the day of surgery. They didn't sit in the hospital waiting before their surgery. So no surprises, I think there, and then we do just fine. So also no significant change in the average time of theatre. We see that there is a bit of a drop in average time in theatre, and we think also that it perhaps has to do with changes in protocols, with more local anesthesia for knee replacements. Richard Stein, he has been very much involved and really written a lot of the protocols, but they have not been enforced as such. But there is definitely some changes in practice, what we see. And perhaps that could explain that the average time in theatre has changed a little bit. So that is how we can start looking at the data. Here you can see the time, the duration of a theatre, and then broken down by a surgeon. So pre that time and after the time, so we can get much more engagement with the surgeons, and definitely orthopedic surgeons. They're actually quite competitive in nature. So when you put kind of data in front of them, you get engagement. And they can see also their improvement when we look at the time before or the time after, so we can start breaking down the data quite significantly and start showing them what they're doing. And you have always to be careful how you look at data, because one surgeon does perhaps the more complex cases. So it's always the anecdote. What you need to have is the data. Data by itself is a danger, but just anecdote is also assumption, is also not good. So you always have to bring those both together. So special care unit, we spoke about it, but we never actually did anything with it, and then perhaps the team is going to look at it again, but we also see that all patients still passing through special care unit, I believe, most patients. But there was discussion for not every patient perhaps need to go through that unit. So I believe there is still a little bit of an opportunity. Mobilization within 24 hours, that is such a data set that we don't capture in the patient management system. So as part of the collaborative, we capture that data manually. There is always a little bit of issues with it. But I believe that Canterbury already did quite well. So the dark line is Canterbury, and the blue line is the national average. So there were those 20 DHBs that provided also data to the ministry. So that is where we actually, and I don't think that there are any other specific changes. I've spoken with Richard earlier in the week, and he actually believes there is much more assertive management and faster mobilization of patients after knee replacements. So I think that's definitely make a difference. So we don't have any further data after 2014 on that one, because we stopped manually collecting the data. And I think this is where we see something significant changes. The 3 nights, 4 days gone that the team set itself, it was just acknowledging that nurses and often the MDT could discharge a patient when they were okay, but they had a little belief that patients need to be in the hospital 4 nights, 5 days. But then with the right discharge criteria, when it's appropriate for a patient to go, they should be able to go home. And I think it has been significantly an improvement what we see in patients that are now discharged 3-4 months. I don't know, girls, what is happening the last few months. I think it seems to have dropped a little bit, but we were meeting 90% of the patients that they were discharged. So it's quite significant. And when I would put this all together, then you would see all the D's, so there is a significant change, that is statistical significant, that there has been a change in the process, because you have 8 data points or more above a mean. Yeah. So I think that was definitely very interesting. We were very interested in these charts, because we saw in the beginning that on Thursday there was a high volume of total knee replacements. But when you go through 3 nights, 4 days, that means that you have to discharge on Sunday.
Yeah.
How would we discharge on Sunday? So here the data actually shows those patients admitted on the Thursday, that actually the highest number, 82%, is discharged within that 3 nights, 4 days. So that is quite significant, but that is how you always have to start looking at the data. It just tells me that there are good discharge summaries of discharge criteria, or the teams are speaking well with the surgeon, or the surgeon is very clear about when the patient is fit to go home, mobilization of the patient is happening in the weekend, all those things come together and we don't see an adverse effect. So that is actually quite of interest. So where does it translate to from a DHB perspective? Hey, the volume has increased, but the occupied beds for the patient cohort has actually decreased. So theoretically you say, hey, that is a saving, but you only make real savings in the health system when you close a ward or something like that. But I would have to say that we definitely do more with the same. That is definitely what it tells me. So it's very cool. You always need the balancing measures. When you make changes within the system, you have to understand, does it have any adverse effect? So we looked actually at mortality, but the last mortality of a knee patient, I think, was in 2013. So there are no really data charts on it. These are readmission charts. That is within 3 days, and that is within 28 days. And as you see, it's very much the same when you look with the break, so there are no adverse consequences with the changes that have been made in the systems. So after 2014, this was a little bit of the feedback of the teams. Data is very good to have. I think also to have it managed a little bit as a program, to be involved, to a clinical team, was very good. Not full buy and achieved by all surgeons. I think that continues at times still to be. So this was just some feedback of the team after 2014. As for me, the main learnings is data without observations is really assumptions, and observation without data is an anecdote. I think it's very important. What we really have seen is clinical teams bringing the clinicians together and supporting them with the high data and providing the feedback. Software allows us to answer data on the fly, so I can sit there and I can say, oh, when are those patients coming in? What time of the day are they coming in? I just put it in and I can show it straight away. It's very powerful in that way. So the data and the information and the technology that we have now can really support those kind of discussions. So that has been good. I believe it was a very good exercise where it was an MDT approach. That is in Berwick has been always very good in involving the MDT. The length of stay is a measure. It's easy to count and it's easy to measure, but you have to be careful also, because we could park patients from here and we send them to Ashburton, or we send them to a rural hospital, and you have to calculate that also in. So you always have to know what you actually do. So the balancing metrics. For clinicians, and I think that is where we still have to do work in the organizations, how we really report on the clinical outcomes on the functional levels, definitely for rehabilitation. I think that is also important. And I think we have been able to introduce the ad hoc data with an S event, so that's going to be a very nice piece of work as well. So there are always opportunities to do things different, and at the moment we're going to extend it to more pathways. I think the next generation of improvement within a health system. We've done what we can do, the low-hanging fruit, what people say. So the next phase is really about specific cohorts of patients, the clinical pathways, to improve those ones. So that is the next phase, I would say. And I just want to leave you with some comments of the team, but that is all what I have to say.